The TRACC study is a UK multicenter prospective study, and this is a network of oncologists, of surgeons, of researchers, all interested in early bowel cancer, so stages 1 to 3 colorectal cancer. And the study is led by Professor David Cunningham at the Royal Marsden Hospital. It opened in 2016. This was with the vision that we bring liquid biopsies into clinical practice once we have validated, its utility really in a translational study which is prospective. So this study now has over 800 patients recruited during this period of time as part of our observational study. And out of the 800 patients, we analyzed the plasma samples of 122 patients, stage 2 and 3 only at this stage. And the analysis was done using the Signatera assay, which some people may be familiar with. It's a tumor-informed assay where whole-exome sequencing of the tumor tissue is done, and the data, in terms of the sequencing data is then utilized to generate personalized multiplex PCR assays. And the plasma is sequenced using the top 16 single nucleotide variants. So the top 16 SNV is chosen, and in a longitudinal fashion, all of the subsequent plasma samples are analyzed to see if there is either the presence of ctDNA despite this potential curative surgery that our patients undergo, or if there is absence but then a late emergence of the ctDNA. With regards to the technology itself, it's already been tested in quite a few studies. With regards to perhaps the difference in the methodology and the approach is that we've had a prospective collection. This is obviously retrospective analysis, but the key things that we wanted to focus on were really to provide more data in terms of the prognostic value of the test, to see if we can risk stratify patients. We have a good system of stratification right now in terms of stages 1 to 4, and in terms of stages 2 and 3, we have high risk and low risk based on certain pathological features, the tumor and the node. But could we bring in ctDNA is the next question, and this has to be done in a methodical manner. With regards to our findings, which you probably see from our study, we know that 43% of our MRD patients relapse, very consistent with the literature. But if you break it down further in terms of stage 2 high risk, low risk, stage 3 high risk, low risk, you begin to see the differences in terms of how these patients really kind of relapse. So it's perhaps in the coming years we'll probably have a classification where we take the TNM stage, but also add in the ctDNA stage perhaps, and give a further personalized risk score to each patient, which then takes us to the next step. In terms of why is the stratification important, it's really for the adjuvant chemotherapy section of patient's journey. They've had a tough time already. Diagnosed with cancer, they've had the section, and then you move on to the next step. They come to clinic now, and we are really using the stage of the tumor that's been taken out, and you don't know what's left behind. You don't know what the minimal residual disease is right now. And in terms of adjuvant chemotherapy that we offer to patients is very much a one-size-fits-all approach. So everyone with high-risk stage 2, everyone with stage 3 disease just offered chemotherapy. The conversation usually in clinic is, well, this is an insurance policy. Would you like to have it? We don't know. We have some idea in terms of risk of recurrence, but we don't know what your individual risk is. And we can do better. As a oncology community, we have to do better, because these treatments are, they do have side effects, both short-term and long-term. The short-term side effects, again, some people may be familiar with: tiredness, problems with hands and feet in terms of skin peeling, ulcers in the mouth, diarrhea, loss of a livelihood for the period of time that they have chemotherapy, which has such a big economic impact on patients and emotional impact as well. The long-term side effect is this condition called peripheral neuropathy, which can be quite debilitating in some patients. Starts off with tingling and numbness, but in some patients can really affect their mobility, the fine motor function. And chemotherapy has, therefore, we have to use this judiciously in order to select the patients who really benefit from the chemotherapy. This is where ctDNA can make a difference. But again, in terms of how we use the data, in terms of the ctDNA results, we need results tested in a prospective randomized study, which is what TRACC is already doing. So what we did was really built on an observational study, expanded it, and we have an interventional arm, if you like, wherein we are randomizing patients to standard of care, and the patients are this group of patients compared with patients having adjuvant chemotherapy guided by ctDNA. And in the ctDNA guided arm, if they have a detectable ctDNA, then they get the adjuvant chemo. If they do not have detectable ctDNA after surgery, we have a de-escalation approach wherein we're reducing the chemotherapy and not giving the chemotherapy. But we repeat the ctDNA, the test again 3 months after to make sure that we're not missing or under-treating patients who didn't have ctDNA initially, but then develop a kind of emergent MRD at a slightly later stage. So it's a dynamic assessment in that sense. With regards to, obviously our poster is, hopefully reasonably clear, but there'll be publications around the effect of adjuvant chemotherapy, ctDNA clearance, which is a big topic, really, not just in colorectal cancer, but across other tumor types as well. So that's where we are.